Participants here. I'm Edward Jonas from Department of Surgery at the University of Cape Town. And just to say welcome to everybody to today's GECKO endoscopy meeting. Just again to give you the background, we have these GECKO meetings that are managed by the Gastro Foundation, and we thank them for that. They're usually on a Wednesday, and they, as you probably all know, are IBD meetings. There's a HCC meeting, there's a pathology meeting, and this meeting we have once a month. So I received an email from Karen that we have more than 70 registrations today. I think there's almost 40 now, 39 that have logged on, and from 14 different countries. And I think Dr. Lars Oorbakken from the World Endoscopy Organization is, if he hasn't joined us yet, he certainly will later. So welcome to him as well. And it's a real privilege for me to introduce Matt Scriba and Galia Chinnery from the Department of Surgery here at UCT that is going to take us through the ABC of corrosive ingestion management. And they're going to do that as a case based discussion. And then also during the presentation, the chat facility is open, so please pose any questions there. Sandy Thompson, my co-chair, will continue from around 5 o'clock when I unfortunately have to join another meeting. So again, welcome, and I think we can start, Matt and Galia, if you're ready.
Thank you very much, Prof. Can you see my screen? I hope everybody can see my screen. Thank you for the introduction and the opportunity to discuss this rather important topic that unfortunately we are still encountering in this day and age. So acute corrosive injuries still represent a major source of morbidity and mortality, and they tend to be viewed in a biphasic approach. We have to manage them in the acute setting, and unfortunately some of these patients will not survive. But those that do often return to us with chronic sequelae that we then have to deal with at a later stage. For the talk today, just because of time purposes, I'm going to focus mainly on the acute, in other words, the ABCs, the acute management of corrosive ingestions. We'll cover a little bit about the chronic consequences later, but very briefly. From the word get-go, I'd like to say that oral injuries that one sees, so what one sees in the mouth after a patient has swallowed a severe corrosive, does not always necessarily correlate with what we see internally. Some patients will rapidly swallow a very corrosive substance and have minimal oral injuries, but then have severe esophageal or gastric injuries. While on the other hand, if they gargle with the substance, they might have very severe laryngeal involvement, for example, but not actually swallow it and therefore don't have much distally to that. So we shouldn't be in any way misled by what we see in the mouth. Also important is that we mustn't forget that the GIT doesn't end at the pylorus. We very much focus on what we see on endoscopy in the esophagus and the stomach, but we mustn't forget that some of these substances can progress through the pylorus and actually damage the duodenum, sometimes even the small bowel beyond that. And certainly sometimes we see if there's already been a perforation and spillage of corrosive into the peritoneum, that other organs in that area can also be damaged. At Groote Hospital, we are a referral center for major corrosive, so we do see a number of these every year. And those that we manage to survive, those that survive the initial injuries, usually stick around with us for a very long time and keep coming back, and we get very well acquainted. So it's important for us to understand something about these injuries. When we focus on the acute management, which is what I'm going to focus on today, often from the word get-go, when we see them, the question that we ask ourselves is, do we think this patient is going to need acute surgery or not? And this is sometimes quite a daunting question, because if you get it wrong, if you say the patient doesn't need surgery and then you miss a perforation, they of course do a lot worse. And on the other hand, if you take them for a major operation like removing the esophagus and it wasn't needed, that's a significant major morbidity with its own problems. So I'm going to start off, as mentioned, with a case. I'm going to mention the same clinical case. This is a real patient we had recently. And then I'm going to follow that by 3 different endoscopic videos. The first one happens to be his real endoscopic profile. I will then follow that with a poll just to see what most members of the audience would do for this patient based on the scope alone. And then we'll repeat that process with 2 other scopes where it looks a little bit different, just to see how the management can be rather difficult based on endoscopy. So this was a 35-year-old male patient that presented to us about a day after an intentional battery acid ingestion. There was significant intent in that he actually took his battery out of his car, unscrewed the lid and swallowed the acid, and then arrived to us, as mentioned, about 24 hours later. He looked clinically quite well on arrival. There was no airway or respiratory compromise. He didn't appear septic. He was hemodynamically normal and had a soft abdomen. And the mouth wasn't very impressive, a little bit red and inflamed in the buccal mucosa, but otherwise looked quite well. So I'm going to follow by showing you what his endoscopy looked like at this point in time. So starting from the top, going under the epiglottis here, we can see that the larynx and the whole pharyngeal area actually look very normal. So there's no major corrosive injury here. And as we progress through cricopharyngeus, we can see that the esophagus starting to look a little bit sluffy already. Just going to wait for it to progress down a bit. So we've already got evidence of injury in the esophagus. No major ulceration and certainly no necrosis that one can see here in the esophagus, which makes us happy. A lot more slough distally. And as we progress down into the stomach, we can see that it's a little bit more severe in the stomach. So you can see a lot of slough, quite a bit of fluid that's obscuring our view a bit. There's certainly possibly areas of ulceration distally here in the antrum. And very important is here that the pylorus is widely patent, and distal to that, as I mentioned in my introduction, is that the duodenum is not normal. So the duodenum is involved here. We're going into D2, down into D3. It's not quite involved, but at that point it started to look normal, about D3. And then very importantly, when we come back and retroflex, that we can have a good look at the rest of the stomach, coming out the pylorus now. And on retroflexion, we can see that there's quite a significant gastric injury. And there's certainly ulceration, and initially there was concern of necrosis, but most of that is sloughed off already, and the underlying tissue is at least red and not completely necrotic. So I'm going to ask just that we do the first poll. So based on this video, we're going to just put up a poll quickly. So based simply on these endoscopic findings, what would be your best next course of action? So there's 4 options. First one is to do an emergency esophagogastrectomy. Secondly, an admission with prophylactic steroids and antibiotics. Thirdly, an emergency total gastrectomy, in other words, leaving the esophagus behind and then planning for a delayed reconstruction. Or lastly, placing a nasojejunal tube for feeding and then admitting the patient for close observation. I'll give you all a few seconds to just submit your answers. Okay. Can we close that poll? Okay, so we can see that the majority of people will place a nasojejunal tube and admit for close observation. I'm going to go through the cases again at the end, but this is what we did for the patient at the time. Now I'm going to change the scenario slightly. So it's the same clinical scenario, same patient that appeared clinically well, no major oral injuries, no airway compromise, but his scope now looks something like this. So this is already going down into the esophagus, and you can see it looks vastly different. Certainly evidence of necrosis in the esophagus. There are perhaps islands here and there of what appears to be some healthy tissue, but the majority of the esophagus looks necrotic. There's also quite a lot of black fluid lying around, lots. And as we go into the stomach, it doesn't insufflate very nicely, and it looks very worrying indeed. Difficult even to get through into the duodenum. So the same poll we're going to ask now. If we can just put up that poll, what would you do for this patient? So it's the same question, the same 4 options: an emergency esophagogastrectomy, admission with antibiotics or steroids, only doing a gastrectomy, or placing a nasogeginal tube. All right, I think that's probably enough time. Can we close that poll and then we'll proceed? Thank you. Okay, so the spread is a little bit more spread out here. People not as clear as to what should be done here. And I think this reflects how difficult it is to make a decision based on endoscopy alone. And we'll cover this a bit later. I'll tell you, in reality, this patient landed up having an emergency esophagogastrectomy, but we'll come back to this at the end. And then the last one, a third video, perhaps somewhere in the middle of the first and the second one. So we're going down the esophagus again here. It looks a bit red and perhaps inflamed, but there's no sloughing yet. There's no real ulceration, certainly no necrosis in the esophagus. And we're coming up to the OG junction here. Looks a little bit worse here. And as we get into the stomach, there's certainly some necrosis on the greater curve here. But as we go through onto the lesser curve, it looks nice and healthy at the top. Antrum and pylorus are very nicely spared, although there's perhaps a little bit of slough or ulceration there, and pop through into the duodenum, and it looks very nice and healthy. So the last poll for the afternoon, we're going to ask the same 4 options for this patient now. Okay, and let's close that poll. And perhaps even more spread out here, difficult one to choose from what we would do. And we'll cover this at the end, and we'll go through that after this. Okay, so what I thought we should talk about today, if you look at any talk on corrosive ingestion, you always have to have some sort of discussion around the pathophysiology. So I'm going to briefly mention that. Focus mainly on, as a management, the management of the acute corrosive injury. And then briefly at the end, just a few slides on the chronic corrosive management. This is a rather broad topic, and you can devote an entire afternoon to this. So we'll just cover this very briefly at the end. So on the pathophysiology, if one reads any text on this, the traditional view or the traditional approach to the pathophysiology is always to break it up into acids and alkalis. And acids cause a coagulative necrosis with Eschar formation. They tend to be more liquid than alkalis, therefore they have a faster transit. This means there's shorter contact with the mucosa, but on the other hand, they can spread a lot further down the GI tract. They tend to smell and taste a bit worse, therefore, if it's not an intentional ingestion, the patient tends to ingest less than an alkali, for example. I'm certainly seen in the pediatric population. They do cause some pylorospasm, which means it can accumulate in the antral area and predominantly cause an injury there. If the patient lies down and it flows back into the fundus, you may cause an injury there. And based on all of these factors, the traditional view has always been that the stomach is more injured than the esophagus when patients drink a strong acid. On the other hand, alkalis cause a liquefactive necrosis with associated vascular thrombosis, and therefore cause a deeper injury with ongoing damage over the next hours and days. And because they, unlike the acids, tend to arguably taste a bit better, they're a bit more palatable in most cases, the patient can swallow a greater quantity, therefore cause more injuries. Now, this is the traditional view, but I'd like to say that in reality, when a patient takes a massive ingestion of either of these, whether it is an acid or an alkali is arguably clinically irrelevant, because the injuries can be quite similar, and we certainly don't manage the patient based on whether it's an acid or an alkali. So this view is important, and often registrars get asked about this in the exam, but whether this is clinically relevant remains to be seen. What is important is to note some of the other factors that influence the pathophysiology. So when you talk about degree and characteristics of injury, there's a few human factors that usually influence how the injury or how bad the injury is. Pediatrics versus adults. We don't get any pediatric patients because they go to Red Cross hospitals, so we don't see those. But they, for the most part, thank goodness, tend to be accidental injuries and often less corrosive substances. Therefore, the quantity swallowed, etc., is less. While in adults, which are the ones we see, the majority are intentional, so suicide attempts where the patient can swallow a large amount of very corrosive substances. The other important thing is to ask what happens after the patient ingests the substance, because vomiting, aspiration, and taking other substances may all worsen what happens to the patient. Other factors about the corrosive itself, so not just acid or alkali, is the concentration, the pH, the volume of the ingested substance, and the viscosity, because these all influence contact time with the mucosa and how badly the mucosa is burnt, or the wall of the GIT is burnt. And then we also have to remember, sometimes we forget that some of these corrosive agents are quite volatile, and the vapors can cause airway and respiratory issues. And once a patient has a significant corrosive pneumonia, their outcome is severely worse and they've got a very high risk of mortality. So I think that's enough about the pathophysiology, but it goes to say that we shouldn't just view them simply as acids or alkali. There's a number of other factors that influence the injury. So let's move on to the main focus today, which is the acute corrosive injury. And I think if any person saw a picture like this after corrosive injury, they'd move to intubate the patient rather quickly because the edema progresses and they will obstruct the airway quite quickly. When we talk about the initial management, I'd just like to put this slide up because it's important. We still every now and then see that people do this. There's no role for attempting to lavage the stomach, trying to neutralize the pH. In other words, if they've taken an acid, to give them an alkali or vice versa. There's no role for activated shock or induced emesis. All of these things potentially make the injury worse and should be completely avoided. There's also no role for routine nasogastric tube placement. It's very uncomfortable for the patient and it tends to induce vomiting, which increases the risk of making the injury worse and aspiration. At present, there's also really no evidence to give the patient prophylactic antibiotics or proton pump inhibitors. And steroids really have no role in the acute setting. They also haven't been shown to reduce future chronic stricture formation. Perhaps one area where you can give steroids is if you have, like the picture I showed you just now, severe airway edema, then you might consider steroids. But for the gastrointestinal tract, there's really no evidence that steroids do anything. So it's really quite simple. In the acute setting, we manage the patient very much in a supportive manner, and we then have to decide whether or not they need surgery. So what we want to know is how severe is the injury, and the severity is usually related to the depth, almost like skin burns. We want to know how deep the corrosive has burned through the layers of the GI tract, and then of course the extent, in other words, which part of the GI tract is involved. And as mentioned earlier, we then want to decide, does this patient need urgent surgery or not? And this can be quite a difficult decision. And I think the polls we put up have shown that there's quite a varied view on this, even in this audience. So on the one hand, there are some patients who you will see who definitely need surgery. And these can be hopefully reasonably easy to identify. And those are the ones that have already perforated. These shouldn't be missed. So if they present with signs of obvious sepsis, bearing in mind that corrosive injuries induces a sort of a SIRS response that can look like sepsis. But if the patient is overtly septic with septic shock, you should consider that they've had a perforation. Gastric perforations tend to have peritonitis. They might have free air under the diaphragm on chest x-rays. Esophageal perforations are a bit more subtle. The patient may have some subcutaneous emphysema in the neck or some air on the lateral chest x-rays, prevertebral air. But unfortunately, fortunately, it is uncommon to see a patient with already evident perforation, but often it's a lot more subtle to decide whether they need surgery or not. And they need to be further investigated. So what are the best investigations that you can do to determine whether the patient will need surgery in the acute setting or not? So the first thing we do, and I think most centers will still do this, and arguably, I think most people will agree that endoscopy is still the initial investigation of choice for these patients. The advantage is that you can directly visualize the mucosa. You can grade the injury, and I'm going to talk about the Zagar grading shortly. And you can also see the extent of the injury. So you can see which part of the GI tract is involved all the way down to D2, perhaps to D3 if you go a bit further. The old teaching that it's not safe to do an endoscopy after 24 to 48 hours after the corrosive is not really true. If you are an experienced endoscopist and you use minimal insufflation with a gentle scope, it is safe to do endoscopy in the acute setting, and we will certainly scope the patient even 4 or 5, even a week after the injury. There are, however, disadvantages to endoscopy. It's not perfect. The first and big problem is that, as we showed you in that second video, you can see necrosis, but you don't actually know how deep that necrosis extends. Is it just the mucosa? Is it into the submucosa? Is it into the muscle? Or is it right through? So that can lead to problems. And we know that if you use endoscopy alone, you will get the decision to operate wrong about 15% of cases, and you'll do an unnecessary resection. After about 48 hours, even already in that first video that I showed you, there was already slough building up in the esophagus, and certainly after 48 hours, it can be very difficult to visualize things properly because it can be really edematous. It can be lots of slough, making visibility difficult. And we do know that endoscopy carries an inter-user variability. Junior endoscopists may very well incorrectly grade the injury if we only use endoscopy. So if we're going to classify acute corrosive injuries, the Zagar classification has been around for very long. It was first published in the seminal paper in 1989 already, so 32 years already, and was based on an endoscopic grading system that was there before. They simply modified it. But what the group from India did in 1989 was publish a 41 patient case series of acid corrosive injuries. Now that's important because up to that point, most of the literature was dominated from Europe and America, where almost all corrosive injuries are alkali. And the traditional teaching that acids really damage the stomach and not the esophagus was based on this. And what Zagar et al. Showed is that in these 41 patients, the degree of corrosive injury to the esophagus was equal to the stomach. And certainly we know that acids can injure the esophagus as well. And then they also brought forward this classification system that's now probably the most widely used worldwide for corrosive injuries. And it's based on skin burns, and I'm sure most of you have seen this. This is a slight modification, what we would use now. 0 is normal and 4 is a perforation. 1 is a very superficial injury. 2 is some form of ulceration. Either A is when it's localized or B is more extensive. And 3 is once there is necrosis. 3A is focal and 3B is more extensive. And it looks something like this. You can see grade 1 is superficial. It's red. There's no real ulceration. In grade 2, we've got some specks of ulceration here, while this is a lot more extensive in grade 2B. Grade 3A, you can see a little bit of an area of necrosis here. And then these are both pictures of grade 3B. This is extensive necrosis, and it can either look white like this or dark black. This is on a narrowband imaging endoscopy picture. So what is the relevance of this classification system? Does it actually influence anything? The answer is yes. So it's been validated to show that when you move from grade 1 to grade 2 to grade 3, the mortality increases by 9-fold. So there's certainly a mortality association. And also you can use it to predict stricture formation. Once you have a 2B, there's up to 70% risk that the patient will have a chronic stricture in the future, and therefore you can't just discharge these patients, they have to be followed up. And once you get to 3B, there's almost 100% chance that they will stricture if they don't need acute surgery. So this is what Zagar has been used for. It is still useful, it's reproducible, but it has some drawbacks in that if you use Zagar alone, as I mentioned, you will get the decision to operate on the patient wrong a number of times. We also have to apply a different classification to what we see in the esophagus, to the stomach, to the duodenum. So is there anything else that we can use other than endoscopy? And the answer is yes. So CT scanning has now become a lot more popular, and most current guidelines will advocate that you should use CT, contrasted CT, to help you certainly assess the patient initially, but also make the decision or help you make the decision whether they need an operation or not. If you believe the literature, they'll tell you it actually outperforms endoscopy at selecting patients for acute surgery. It's not as invasive as endoscopy, and it tends to be available in many centers. We're very lucky at Corrosive to have 24-hour access to CT scanning. This is, of course, not the case in many centers throughout the world, and CT isn't always readily available. It was first published as a specific grading, CT grading system in 2010 by Rule et al. And they have 4 grades to the corrosive injury. This is rather a little bit confusing, as perhaps not as user-friendly. It's been slightly modified. And from this quite nice review in the Lancet in 2018, a more simplified CT grading system is now being used. It's simply 1, 2, or 3. 1 is normal. 2 is where there's already edema of the gastric or the esophageal wall. Importantly, in grade 2 is that you can see that on contrasted imaging that the wall still enhances. So that means there's blood flow to the wall. While grade 3 is when there's transmural necrosis. And this basically, you can see on this image here on the right, the entire stomach basically doesn't enhance. And this is equivalent to transmural necrosis. And these patients will need emergency surgery. And you can, of course, also on a CT sometimes see if a perforation, a contained perforation has already happened. So CT is considered quite useful and is being advocated for more and more. There's a couple of other investigations that people are now advocating for. I'm just going to talk about EUS very briefly. There are some papers from Japan specifically that are really advocating for this. Theoretically, you can use EUS to determine the depth of the injury. They've also said you may, well, like with the Zagar classification, predict stricture formation in the future. But at present, there's no evidence to say that it outperforms endoscopy or CT and that it actually improves anything. And it's certainly not readily available in most centers in the world. So I think at present, EUS doesn't really have a role in the investigation of acute corrosive injuries. So just focusing, we are from surgery. We want to know whether the patient needs an operation or not. And this is a very important decision, as I've mentioned before. So when we decide this, the considerations we have to take into mind is that we don't want to miss a perforation and delay the patient for theater, while on the other hand, these operations are usually major resections and we don't want to do these unnecessarily. Bearing in mind that only 6% of acute corrosive injuries will actually need acute surgery. So it is the minority, but those that do have quite poor outcomes. So perioperatively, only 21% will die perioperatively, while the outcome after 10 years is only 50% survival. Those are quite bad numbers and a little bit depressing, but we do have to keep that in mind. The other thing to keep in mind is that what you see initially on your scope is not necessarily what it will look like a few days later. Corrosive injuries evolve and perforations can occur late. So sometimes you admit the patient, you watch them, they may not have extensive necrosis, but they may suddenly perforate on day 5 or day 6. So you have to keep an eye on them. So what are the indications that the patient needs surgery for an acute corrosive? Well, the first and most obvious, as I've mentioned, is that if they've perforated already, I think that's clear cut. The question about Zagar 3B, which is what most people would say, if you see a Zagar 3B, the patient needs an operation. These are the patients that are 15% of them will be incorrectly operated, unnecessarily operated upon. So therefore, the thing is that we should use, apologies for that, that should say contrast CT. If there's non-enhancement, as we mentioned, then those should go to theater. Okay. So once you've made the decision, what do we actually do in theatre? So the surgical principles are quite simple. We should remove, firstly, obviously, all necrotic tissue. And often that means the esophagus and stomach. We, in our setting, tend not to reconstruct in the acute setting. And most people will advocate for this. This is because fibrosis is often still developing and may still declare itself in the months to come. Internationally, most people will wait 6 months before they reconstruct. The problem is the patient is usually in hospital during this time because they, for the most part, have a feeding jejunostomy, and we can't send our patients home with continuous feed, so they stay in hospital. So we usually wait 3 months and then aim to reconstruct them. And then always in the back of our mind, in some patients, unfortunately, one has to consider futility from the beginning, and some patients may need to be palliated if the injury is too extensive. So what are the surgical options we do? Well, this depends on what the injury is. For the most part, as mentioned, we would do an esophagogastrectomy. So this involves an upper midline incision, as shown here on the picture, a left neck incision, and then we do a total gastrectomy, and the esophagus is removed transhiatally, so there's no thoracotomy. In the rare instances where only the esophagus and not the stomach is involved, this is very uncommon. You may consider doing only a transhiatal esophagectomy, and then you can use the stomach to reconstruct them later on. Sometimes the esophagus is spared and the stomach is involved, for example, in the classic acid injury, which is also uncommon. And the question is then, you're left with an esophagus, what do you do with it? We've removed the stomach. There's some evidence to suggest in high volume centers, in expert centers, an early reconstruction to do an esophagojejunostomy is safe. But if you're unsure, the safest thing to do is to drain the esophagus and then reconstruct them in a delayed fashion. If you read the literature, there's some more extensive surgeries being done in some areas. So if other organs are necrotic and you want to salvage the patient, obviously they will have to come out. So there's descriptions of colectomies, pancreaticoduodenectomy. So these patients are often having an esophagogastrectomy with a Whipple's, which is a massive undertaking, and is certainly not something we've done in our setting, and not sure whether we will. And then, of course, you can also remove the spleen if that's involved. So here's a picture, an intraoperative picture. It's two separate pictures. On the left here, you will see this is the stomach. It's almost completely necrotic. There are small areas or patches that look okay. And this stomach had already perforated. And on further mobilization, on this side here, on the right, what you're seeing, this is the pancreas. This is the DJ flexure here, and the jejunum lifted up. And you can see a patch of necrosis here. And basically the entire duodenum was also necrotic in this patient. And we made the decision, because the patient was already extremely unwell intraoperatively, that this is not salvageable. And the patient was palliated and demised a few hours later. So just to remind ourselves that these injuries can be more extensive than just the stomach or the esophagus. Just briefly, and so what if we've taken the esophagus out? We need to replace that. And this is sometimes a bit of a bone of contention, and is certainly where things can become a bit complicated. If you have the stomach left behind, which is rare, that is the first choice of conduit to pull up the stomach. We often don't have that available, and we're left with having to pull up the colon, and there's much debate about whether you should use the left or the right colon, etc. I think in effect what we do is we see intraoperatively which looks best, and that gets pulled up. If the colon isn't available, we then progress to trying using the jejunum. We are limited because the jejunum has quite a short mesentery. You can't really pull the jejunum up from the abdomen to the chest just on its own mesentery. So you either have to do it as a free flap or a supercharged flap, where you leave it on some blood supply and then do a microanastomosis in the chest, either to the internal mammaries or the inferior thyroid artery. And then there are a host of other things where you don't have options left in the abdomen, other flaps that you can use to reconstruct the esophagus. I'm not going to go much into that. Here's just a picture of what, if you do have the stomach to use. So this is more in cases, for example, where we do esophagectomies for cancers, but every now and then we're lucky. And what we do is we then tubularize the stomach from the lesser curve using a linear stapler, progressing parallel to the greater curve, and we tubularize the stomach. And if you're lucky, you are left with a nice tube of stomach like this, with a beautifully pulsating right gastroepiploic artery supplying your graft. As said, we often don't have this available, and we have to use the colon or the jejunum. I'm just going to show you one case out of interest where we didn't have any of those options. We'd already pulled up the colon and it unfortunately became ischemic, and we were left with a long 15-centimeter gap. And in this case, we opted, and the abdomen was completely frozen, so we couldn't use jejunum. So we opted to use an anterolateral thigh flap. So this is using skin and subcutaneous fat. We left the muscles in situ, and with the help of the plastic surgeons, we basically formed a tube as the esophagus, and we used this part of the thigh flap as a soft tissue cover. It was left on its blood supply here, and then this was anastomosed to the internal thoracic artery and vein. This was the end result cosmetically. The patient's head is at the top. And a scope done about a week later then revealed, as you can see here, you go from the native esophagus down into what looks like a hairy thigh skin esophagus replacement. And as we progress down, you eventually reach some of the colon that had survived at the bottom of the graft. So that's a bit of an extreme situation, and we hope not to have to be in a situation like that again, but that's sometimes what the options we're left with. So I'm going to now go back to the cases that we had at the beginning. I think most of you selected for the first case that was a video showing a bit of a sloughy esophagus, maybe areas of Zagar 2B in the stomach. We did place a nasojejunal tube, admitted the patient for feeds, observed him for a while. He did very well, and we managed to discharge him without any surgery. And we are now going to, that was about a few weeks ago, and he's going to come back to be followed up because no doubt he will stricture up. The second video is perhaps the controversial one in a way, because we just have an endoscopy. It was certainly a Zagar 3B. And this patient went for an esophagogastrectomy and had evidence of full thickness perforation. But this is the group of patients where that 15% comes in, that maybe you will unnecessarily do an esophagectomy if you only do an endoscopy. And certainly these are the patients, if they're stable with no signs of peritonitis, that one might argue, advocate for a CT scan in these patients. And then lastly, the third video, that was a little bit sneaky from us, because what you don't really see nicely on that video is retroflexion of the stomach. We only saw going into the stomach, you could see what looked like a healthy lesser curve and antrum, but on retroflexion, actually this patient had complete necrosis and then became peritonitic and was taken to theater and landed up with a stomach that looked like this. So what we saw on endoscopy was this part looked very nice and healthy, but the majority on the stomach is completely dead. And again, just shows how difficult it is to make these decisions based on endoscopy alone. Okay, I think that's enough for the moment on acute corrosives. I want to just briefly say one or two things about chronic corrosives. So the complications in the chronic setting are predominantly strictures, and most of the strictures are in the esophagus and the antrum. We do get other strictures, so you can have mid-body gastric strictures or entire gastric strictures. These are rare, but we do see them. And we always have to bear in mind that an acute corrosive injury is a significant risk factor for future malignancy. So once you've taken a corrosive, your risk of esophageal SCC increases by something like 1,000 to 3,000 times. But bear in mind, this doesn't happen acutely. It happens up to 4 decades later. So there is a role for surveilling these patients. There's not much evidence on what the actual risk is for gastric cancers, but it certainly is a risk factor and should be surveilled as well. And then there's a number of other much less common complications that every now and then one can see, and these include fistulae. We did have a case of a aortoesophageal fistula last year, which is very scary. So any patient that comes in with bleeding after a corrosive ingestion, this is something one has to have in the back of one's mind. Here's a picture of what a typical corrosive stricture might look like in the esophagus. So what do we do for these patients with chronic corrosive strictures in the esophagus? I think from the word get-go, we can never underestimate how important nutrition is in these patients. If they're extremely malnourished, you may start trying to solve their problems, but if you don't get the nutrition right, you're going to fail. So it's important to keep that in mind. Unfortunately, there's no real proven technique to prevent strictures or reduce stricture formation. Lots of things have been tried, including steroids and mitomycin, early nasogastric tube placement, etc. Nothing really has been shown to work. So what you need to do for these patients is surveil them, and then when the strictures occur, you have to then manage the stricture. Contrast swallows are very useful. I didn't mention that in the acute setting we do sometimes use them, but they are most useful in the chronic setting because it allows you to see where the strictures are and the length of the stricture and how many strictures there are, because corrosive strictures in the esophagus often may have more than one stricture. And the management options are there's a number of management options. We, for the most part, do endoscopic management as much as we can before we do surgery, because surgery in the chronic setting of corrosive injuries for the esophagus is really horrible surgery. It's difficult. There's lots of complications. So the endoscopic management is always something you should try first as much as possible. There's a question about whether you should use a bougie or a balloon to dilate. I'll talk briefly on that. Stents do have a role. It's a little bit controversial, but we certainly use them. And then there's a number of adjuncts that people will try. These include incisional therapy, so using something like an endoscopic needle knife, injecting steroids into the stricture, and a number of others that are starting to be used. If you do have to operate on these patients, for the most part, if you're operating for an esophageal stricture, the question is whether you then do an esophagectomy, in other words, you remove the esophagus, or whether you just bypass the esophagus and leave the native stricture down esophagus in situ. This is a difficult decision. I'm not going to touch much on this, but the concerns are with leaving it in situ is that you form a mucus seal because the esophagus is still producing mucus, and of course the ongoing risk of cancer. But of course, operating on a stuck down esophagus is extremely risky and has multiple possible complications. Other forms of surgery are much less commonly done, and we won't generally attempt things like stricturoplasties. I think there's not much role for that. Using a bougie to dilate the esophagus, so we use these Save-Regulard or SG dilators, which you see on this picture here. I think that's the standard way of dilating esophageal strictures from corrosives. There's no real evidence to say that balloons are better or worse. There's certainly differences. Bougies allow you a biaxial dilatation because they are, first they go to a specific diameter, so there's a radial dilatation, but they're also tapered. So you get a guaranteed diameter of dilatation, and you generally can feel the stricture a bit better as you dilate it compared to a balloon. A balloon has a set diameter, you've got only radial force, and the concern is that then your perforation rate is increased. There's no evidence for that, but we certainly are a bit wary of balloons in corrosive strictures. What about stents? They are still considered somewhat controversial, not particularly well studied. There is some evidence on them that they do work. In reality, they are being used more and more. We do find them useful in certain situations. There was a lot of initial focus on biodegradable stents, plastic stents, lots of concern with any of those, and they haven't really taken effect. The standard stent we would use would be a fully covered stent, similar to what we do for our cancer patients. And they are placed in a temporary fashion, so it's not there for permanent use, because they all tend to migrate if you leave them for long enough. So we would remove them 3 months later, often before that. And some of the uses we would use them for is if you have a very long, tight stricture, and certainly in a patient that has poor nutritional status, that won't tolerate a perforation, a stent allows you a safer form of dilatation because it will still expand and dilate that stricture over a certain time period. You can then remove the stent a few months later after the patient has been able to eat and looks a bit better, and then commence serial bougie dilatations after that. Okay, and then one slide on gastric strictures, and the most common presentation for these patients is gastric outlet obstruction. This is quite a broad topic, and there's lots of complications and problems with these patients. They can be quite difficult to manage. As I mentioned, most of them are antral strictures, but you every now and then see a patient with a mid-body or pan-gastric stricture. These are even more difficult to manage and usually require surgery. Management is in the literature, and what we do in reality is quite often based on what has been done for esophageal strictures. The endoscopic management is becoming more and more popular. And as with esophageal strictures, most authors will advocate that you should try and do endoscopic management first, and you will have a reasonable amount of success. And endoscopic dilatation is using a balloon. We obviously can't use bougies in the stomach. Stents are even more controversial for benign gastric outlet obstruction, but there's perhaps a role for them. And we more readily operate these patients because the stomach's a bit more accessible than the esophagus. And then the question is, what do you do for these patients? Would you go and do a resection? Would you bypass them or do something like a pyloroplasty? And I think that's a discussion for a whole nother day. Certainly one of the biggest series on corrosive ingestions causing benign goo is from Kocha et al. This is from India, a very big series of about 300 patients with benign goo. The vast majority of these are corrosive ingestion. So if you want to read more on that, that's quite a good article to read. Okay, so I think I've said enough today. I just want to conclude to remind us that corrosive ingestions unfortunately still carry a high mortality and morbidity burden, certainly in our setting. The initial management is actually quite simple. We give the patients analgesia, IV fluids, and focus on nutrition. All the other adjuncts and things tend not to work, steroids, antibiotics, PPIs. And most of our initial decision-making revolves around whether or not we think the patient will need surgery. It's challenging. And I think what we are starting to do and what we probably will aim to do in the future is to add contrasted CT more and more to our algorithm, especially in those patients with necrosis, where we're not really sure if a surgery is outrightly indicated or not. Thank you very much.
Thanks very much, Matt. That's really quite a fascinating and thorough expose of the whole topic. There are quite a few questions in the chat box, and perhaps I can make a start with them. The first is, does black mucosa equate to transmural disease? And you may have answered that to some extent. And do you think endoscopy does help to decide whether you're going to sacrifice organs or not, even once you've made the decision to operate because you think at least one of them is perforated? Perhaps you could tackle that.
Yes, so I think what we've shown, or what is evidence, is that black mucosa does mean there's necrosis, but it doesn't mean there's transmural necrosis. This is the biggest drawback with endoscopy, and this is where that 15% comes in. So for the most part, if the entire stomach is black and the esophagus is black with necrosis, the chances are extremely good that you do have transmural necrosis, but every now and then you are wrong. So it doesn't necessarily mean that. You are only viewing it from the luminal aspect. You cannot, through endoscopy, look through the whole wall of the GIT. And this is the whole argument for why CT scanning is better than endoscopy alone. And the question of whether we should only use endoscopy, then decide whether we should sacrifice organs, I think that's a difficult question to answer. The one thing that one should also consider is that in a patient with a 3B Zagar injury, in other words, there's complete necrosis, even if there isn't transmural necrosis, there's almost 100% chance this patient will stricture in the future. And this is also something to take into account. If you are going in to remove the esophagus and the stomach looks black, I think you'd be hard pressed to leave that stomach behind if it looks normal from the outside, because the corrosive also progresses over the next few days, and you don't want to be in a situation where you've left the stomach behind and then they perforate on day 5 post-op. I'm not sure if that answers the question.
I think that's a good, a very good answer, and something I would concur with. One of the things that you didn't touch on, obviously, generally speaking, most people are going to be seeing these injuries within the first 24 hours or 12 hours of them occurring. And so what is it? The question is, what is the ideal time to do the OGD? And the other question I have for you is, what would make you back off doing the OGD during the procedure? I.e., if you get into the esophagus, is there anything that would make you back off doing the procedure?
So I think the ideal time is, it obviously completely depends on your local resources and how readily you have endoscopy available and what time of the day the patient presents, etc. I think you should do it as soon as possible, and you should be guided also by a clinical situation. If the patient is coming in and is peritonitic and appears to have perforated, then I think you should take the patient to theatre and plan to do the resection. You can always do an on-table endoscopy. Otherwise, if they come in the middle of the night, from a practical point of view, waiting until the next morning is often what happens. Whether that's correct or not, I'm not sure. But it should be done as soon as is feasibly possible is what I would say. I think it very much depends on your situation. What would make me back off while I'm doing the endoscopy is certainly if I am scoping the patient and they suddenly have significant surgical emphysema while I enter the esophagus, because then I've clearly pushing a whole bunch of air through a perforation. And of course, if you're doing an endoscopy in an awake patient or a patient under conscious sedation and there's risk that they're losing their airway, or you go in and the airway looks severely compromised, I think it is wise to stop your endoscopy, perhaps get the patient into theater with a secure airway from the anesthetics, and then you can do your endoscopy and plan what you will do next.
Okay, thanks. I wonder if anybody else wants to unmute and ask some other questions. There are a few more here, but it would be good to hear directly from others. So please. Is
that okay?
Yes, absolutely, Mashiko. Thank you.
Matt, thank you. I thoroughly enjoyed your presentation. I thought it was excellent and instructive. My first question is just sort of a practical one. So you do endoscopy on all patients with caustic ingestion. And then my question is, what prompts you to do a CT scan? Is it because of what you see endoscopically, or do you do a CT scan in every patient after the endoscopy? That's the first question. And then my second question is just, how many patients do you think you've seen in the last while? Because I think this would be really interesting to write it up, particularly because of the, the stuff that you do surgically for these patients. Thank you, Matt.
Thank you, Prof. So the first question, who do we do a CT scan for? That is a good question. And I think CT scanning is quite a new thing, even for us. We haven't really been doing it much. I think it's something we should start doing, certainly because we're in a very fortunate situation where we have it so readily available. I think any patient with significant amount of necrosis, even a small patch of necrosis, you don't know how deep that necrosis extends. So just because it's not extensive necrosis, I mean, the acid or the alkali may have sat in one spot and has burned through that area, and the patient will perforate at that spot. That's an indication to operate. And therefore, I think any patient with true necrosis, you should consider a CT scan. In some patients, I think if you strongly feel you think the patient needs theater anyway, that you think they may have already perforated, obviously we won't scan that patient on the one hand. And then your second question as to how many we've seen, that is also an excellent question, because we are in the process of actually planning to write this up, and we are going to look at our data soon. We do see, I'm not sure, I mean, we'd have to look at it, but we do see a handful, 5, maybe 10 severe corrosives every year that need major initial surgery and significant reconstructive surgery. And they're really time-consuming, resource-consuming patients for us.
I think actually one of the other values of endoscopy is that there are patients who actually have spurious ingestion. You're not really quite sure what the contact time has been. And I think if you have a normal endoscopy in these individuals, you can be really reassured that there isn't a problem and they can be discharged early. So I think endoscopy has that value for determining what are truly very minor injuries or no injuries at all. But my next question is, obviously surgeons and endoscopists are very much focused on the acute injury and whether it's going to cause acute sequelae or long sequelae. But there is a question here regarding what's the ideal time for psychiatric evaluation and what's your approach to that? Obviously, some of these injuries are accidental, and that's another issue, but many of them, and especially in India, a large number of them, that's why they've got so many in their series there, are to do with intentional ingestion. So what's your algorithm, or where do the psychiatrists fit in the evaluation, Matt?
Yeah, thank you. I didn't touch on that, but that's obviously extremely important. There's no point in taking out the esophagus and stomach and getting the patient home, and then they come back with a second episode of corrosive ingestion. So it's vitally important to get them assessed. We do get the psychiatrists involved, and we would do that as soon as the patient is acutely stabilized and is able to. They, of course, the psychiatrists come and take an extensive history and a long psychiatric evaluation. There's obviously no role for that if they're acutely unwell. So we would wait for them to be stabilized. If they've had a significant corrosive ingestion, these patients don't go home very soon. So they're in the ward for a while. We've got some time to get the psychiatrist to see them. But I think, again, you should try and do that as soon as possible. Also, so that if often there's an underlying major depressive disorder that needs treatment, and things like antidepressants take a while to really become effective. So the sooner you can start them, the better. But you also have to bear in mind that the patient has to be stable and that you have to have some form of enteral access to do that. But we get the psychiatrists involved as soon as possible. But obviously, we have to first focus on the patient.
Yeah, thanks. So there's one, and perhaps Lars could, but one of the things that you touched on, and you showed us the case where where you indulged in palliative care. Obviously, you determined the need to operate based on the CT largely now, or at least that definitely seems to be the trend. But obviously, what constitutes would you always explore the patient, or do you think you can decide to palliate without exploring the patient? That's the question. If you decide that they've obviously got transmural disease somewhere.
Well, I think that's a difficult question to answer, and I think there's multiple factors involved. I think if a patient arrives and has a severely poor baseline and is a patient profile that won't survive major surgery, then I think maybe you could decide to palliate the patient, but that's quite a difficult decision to make. Most of the patients we see are young, healthy patients who've decided to commit suicide. And I think you need to, for the most part, make that decision intraoperatively. I don't know, I'm going to ask Galia to perhaps weigh in here. I'm not sure. I mean, one thing I haven't mentioned, it's certainly something we do sometimes, is do a laparoscopy. To start with a laparoscopy, which is a bit less invasive, and actually see what the stomach, etc., look like. But of course, it's difficult to do an extensive mobilization and look at the duodenum, etc., laparoscopically. But there is a role for that as well as a diagnostic part of the algorithm.
Yeah, I'd agree with Matt. I think it's not really often that we have patients that are elderly with poor comorbidities. It's usually the young, healthy patients. So to make a decision to go for palliation without an exploration, I think not really acceptable. And yes, laparoscope will help to guide you. But in a very acute situation with a very unstable patient and a duodenum and a pancreas and a transverse colon, that's a situation where we would probably pull out. But I think this is not to be done just on the CT. It's a clinical surgical decision.
Thanks very much, Galia. Nice to see that you could join us. I know you're very busy clinically, and it's really good to have your input on these really difficult questions. I'm not sure if there are any other questions. I think that's most of what is in the chat box. I think many of the other questions have been answered. And again, we had an excellent talk from the WEO from Dr. Kawinder on how you can use some of these methods for advanced strictures. And again, I think there are plenty of references that you can go to get some definitive answer on that. Even in high volume centers, using some of these techniques on difficult strictures is very much an individual patient and clinical bias as to whether you're going to use some of these different techniques there. I must admit, when I was involved with esophageal work more, when I was in Durban, we had a patient that we wrote up, which was try, and try again. And we used, he had a caustic ingestion of alkali and ruined his pharynx as well as his esophagus. And he had to have 2 free flaps before we eventually did that. And he was in hospital for 14 months. So the morbidity and the disruption of normal life is just quite unbelievable with these very severe injuries that survive. And he survived because of his jejunostomy. And I don't think you can underestimate the value of nutritional support in these people who have complex resections and develop complex strictures. I think we're almost at the appointed hour. I think I'd really like to thank Mac and Galia, who's obviously his mentor, for putting together such an informative talk. I'd also like to thank, obviously, ECHO from New Mexico, our parent sponsor, or not sponsor, but parent technology assistant, and their real technology arm, which is in India, which really handles our interaction, and they provide us with a lot of support. So we're entirely thankful to that. There is a feedback form that we would like you to fill in, again, regarding these talks. And again, we're interested to see if you have any cases like this that pose you difficult management problems that you would like to present to us, because I'm sure you're tired of seeing old grey-haired chaps like me trying to spout forth. It would be good for us to try and advise you on actual cases that you have, and you can see the types of cases that are possible to be discussed, and the dilemmas that we do have. And these GECO meetings, endoscopy meetings, and the other GECO meetings that are taking place are all recorded, and they can be viewed on the Gastro Foundation website. So you have free access to them. And if you believe that some of your colleagues could access them, you can also send them to the link. So please do that. And again, obviously, we've got the ladies who are behind the scenes who keep us on track, and that's Cheryl and Karen. And to them, we obviously take our hat off. They really do run the show. And please respond to their emails and respond to us. It's nice that we've got 50, 60 people still tuned in at the end of the talk. So thanks once again. Next week will be a GECO IBD, and we've got one of our real champions of IBD in South Africa and here in Cape Town, and that's David Epstein, who will be presenting on his IBD Africa project and his website, and will also be using some interesting illustrative IBD cases. So I think that's a good one for you to tune into. So thanks again, and I think at this stage we can leave the forum. Thank you very much, everyone. Goodbye.